Yeah, dear Adonis, ladies and gentlemen, I'm more than happy to be here if there wouldn't be the loss of germs right now against Japan. And I've been listening to Charlie Brown. Do you know Charlie Brown and Snoopy? And he mentioned once, I'm so down, doopy, down, doopy, down. So he took himself out of sadness, and so after loss in soccer, we will have a good discussion right now on challenges of ultrasound in medical education. It is about current knowledge on where we are, the elements of a master curriculum, practical training, the use of simulators, the theoretical and the practical testing, objectively structured clinical examination, and all our challenges we have to face together to make it even better in the future. I could go in detail what I'm going to tell, but why don't I go into detail? So the current state and the knowledge on student ultrasound education is heterogeneous. No existing curricula, perfect curricula, curricula of societies, of universities and students. And I met some of you, and you have really good motivation and a good ultrasound education established in your university. That's great if you compare it with almost everything in the world. So let's see, ultrasound education starts about up to 40 years. 1981 in Hanover, we had ultrasound in anatomy on the living. So we had an ultrasound machine and started as a pilot project to examine cadavers on one side and living healthy students on the other side. And there are a variety of approaches and curricula which differs. And finally, there's a proof on concept. It works. But it works only in few places and not so many. It is difficult to adapt the same ultrasound curriculum all over the world because political issues are different, who is performing, radiologist, clinician, emergency care medicine. There are so many issues we have to solve, and we can only solve together. And standardization is necessary but difficult to achieve because there are so many different issues. It is helpful to have a look to the European Federation of Societies for Ultrasound Medicine Biology. Let's call it EFSUMB. And there are guidelines, free to download, position and state-of-the-art papers, the course book which will be handed out to you for your use and for improvements. So if you get some teaching material, please give me a feedback on how it can be better. So that's a win-win situation between of us. There are examination technique videos on the website which show a transducer position at a certain location and how the transducer will achieve the right image with certain quality criteria. There's a lot about student ultrasound education, papers on the challenges we face together. There are cases of the month if you are interested. We are also working on an atlas. That means an atlas of all ultrasound images which are possible to have it in a structured way that you and we all can use it. And there are also webinars. WFUMB, the World Federation, is working similar, and similar issues and books and videos can be used from the Mother or Father Federation of Societies. So also this book is free to use and free to download. Then we have how to say, to position ourselves from the Federation of Societies, how to motivate students, setting the appropriate goal, that means to have the learning objectives. So what should be part of a curriculum and what should be second and third. We need the support of the deans and the regulatory bodies, and we need practical skills. That means the opportunity to practice, and this cannot be done by the dean. He cannot or she not be at all locations. So we have to build up a peer-student education, hopefully standardized and with high quality. And it needs funding as well. Then the second position paper deals with the ultrasound societies. When should ultrasound be introduced as early as possible? I get often the question pre-clinically or clinically or as a doctor, not as a student. I would say as early as possible. When we learn anatomy, why don't we scan ourselves what we are learning by a cadaver or whatever, and use the image method without radiation exposure and available for all of us. Third issue will be about specialties. That means head and neck, cardio, OBGYN, and issues like that. And who will be partners, who will be standardized lecturing? There are many open questions if we go into a detail. You and we, whatever, examine yourself, and in almost every fifth or even fourth of us, we will find somewhat pathological. And then how to deal with it if you scan as a student, identify, and how to handle such findings. Honestly, it's an ethical issue. And we have also to face incidental findings and how to deal with it. So if you are interested in detail, we have also published a position paper on that. So if ultrasound education in a university is mandatory or elective, depends on the regulatory bodies. So far in Germany, and so far, in Switzerland, it's more advanced. It's part of student ultrasound. It's part of the studies. But for example, in Germany, it's still elective, and it depends on motivation of the people around. And then we have to think about what is the content, the master curriculum. Do we talk about B-mode ultrasound, so grayscale ultrasound? Historically, it was the first issue, but later on Doppler has been introduced as well. And why shouldn't be Doppler historically apart from the conventional teaching? It could be part of our curriculum as well. At least our learning objectives should be specific, measurable, achievable, relevant, and should be learned time-bound. And we will go a little bit more in detail. The regulatory bodies, for example, in the university in Switzerland, the Ultrasound Society and the regulatory body of the state are implemented in each other. They are identical. For example, in Germany, it is the state, the federal state, it is a university on one hand, and the society, ultrasound society, totally different. They have nothing to do with each other. So it depends on regulatory bodies and local authorities on how to handle mandatory or elective ultrasound into student education. As already mentioned, it started many years ago, and now we can go a little bit more into the idea of a master curriculum, and what should a master curriculum for you and me and all of us contain. It is anatomy. We will discuss what is meant by anatomy. It is the topography. That means it is all around an organ we are examining. If we examine the spleen, all structures around could be visualized by ultrasound, identified. It could be part of the learning system. And then it is about examination technique. It is the ultrasound machine, the transducer, it is the examiner, it is the healthy subject or patient, and it is the interaction between all of them. For the ultrasound machine, it is knowledge on how to use all that 50 or even more parameters which can be used to improve an image quality. 50 parameters, take home message. It is the interaction with the patient, who or she might or he might be supine in a slightly left or right lateral position or in a standing position. It's an interaction on how to improve the image quality, and that interaction is unique, not performed in computed tomography or MRI where, yeah, you are in a corner and should not move. And then you and we should talk in the same language. We should have a right terminology. Take home message, we use anatomical terms, not other, how to say, descriptive terms. We use anatomical terms. And then we should have a standardized reporting that you and we all together have the same idea on what we examine. For sure, safety issues are most important. I will tackle one out of it. And then finally, it's difficult at a student stage to learn about pathology which you have not learned in, how to say, your regular medical education. So I've been thinking on how we could define pathology. You and we can learn. And we define it by description and measurement. I will explain more in detail what is behind. So, principles, we should learn about brightness, we should learn about Doppler. Perhaps we might learn about also new technologies. It's fascinating. And safety issues, I will take home, give a take-home message for perhaps one or two. If you examine the eyes, ocular ultrasound, the so-called mechanical index, that means the acoustic power, should not be above 0.23. And don't scan pregnant women by Doppler for your, how to say, beautiful images. There are two safety issues which are generally accepted. Here you can see an eye, ocular ultrasound, you can see the central nerve, you can see almost everything. It is not used in daily routine all over the world as an intracranial pressure elevation. but it's so easy to use it. If there is a little slight elevation over here, you can exclude it before lumbar puncture and whatever. So I stimulate yourself. Ultrasound is allowed in almost everything if you use it in the right way. And there are some applications historically difficult to understand where ultrasound is not as used as it could or should be. Learning objectives should be clearly defined, then they can be easily learned. And there should be a clear theoretical and practical testing, multiple choice question, whatever, on the one side, and OSCE, objective structured clinical examination by experienced examiners and or simulation. And I will show you a little bit about that. Now we go through the learning objectives: anatomy, topography, examination technique, and pathological findings in detail. Those four will be tackled more in detail. On the EFSUM website, and I will also hand it out, we have recorded 113 teaching videos, short videos, where to put the transducer, what to do with the patient, which position, which maneuver to see which anatomical structures, and the quality criteria to say I have seen them regular and can evaluate pathological findings or not. So the position of the patient, let's start with that. And often it is a supine position. And but sometimes this is supine position, and you put the transducer just below, for example, the thorax. And then it could be intercostally approach. So it is often people position their arms like that. No, you have really to widen the intercostal space and turn the patient a little bit to get a sufficient and even optimized image, so you interact with our patient. And who are the enemies of the ultrasound? Bone and air. And if you have a standing position, the organs come down according to the gravitation, and you can better see it. So be aware that during your learning phase, exam always supine, a little bit left lateral, optimize the position for the transducer location, and interact with the patient in a standing position. And then he or she will have to move as well. And then there are few patients where you don't see the organs in the right way. And some people at this point tell me, hey, Christopher, have you never been in an emergency room and they can't stand up? But if they can't stand up, I'm not interested to exclude pancreatic cancer because they couldn't be operated. I have to use in the emergency room if there is free fluid, hemorrhage or whatever. So I don't examine in the standing position. So it depends on what you are doing. And gallbladder should be done. Examination of the gallbladder to exclude stones. Left lateral position.
Fasting period, sometimes with normal, hidden stones and sludge cannot be delineated in one position. Therefore, we recommend please stand up in the standing position, elevate the arm above your head, take a breath. In the standing position, we start the longitudinal and transversal orientated examination, and additionally, we perform some vibrations to delineate mobile stones.
So
it is of importance to examine also in the standing position in patients without known stones for better visualization, and for stones detected in the infundibulum to characterize if those stones are mobile.
So 1 out of those 100 videos explaining a certain topic. And it is not such rare that Keith Richard, Mick Jagger, no, rolling stones in the gallbladder can be visualized only after standing position and interaction with the gallbladder, that they move from hidden corners of the gallbladder to visualization. So then let's have a look to the best ultrasound machine available and the best presets and best transducer. So it depends on resources and so on. You are well equipped to the best of my knowledge. Then we have to use a best transducer for depth penetration, for superficially located organs or whatever. And then touch the transducer where you have connection to the skin. Most important, because you can do the best movements by interaction with the body of the patient. You feel if there is stiffness, pain, contraction. So the transducer with your fingertips, and then first make a translation movement, second turn clockwise or counterclockwise, and only third do angulation. So it's also a deductive process. You might say I can do everything together, but you cannot learn it in that very good way if you do not do that analytic, how to say, movements during the learning phase. Later on, thing together, but that's important. Initial transducer position, that is an example for the aorta, median or a little bit left para median. You put the transducer just below where it can't be more cranial. You put the transducer at this initial position. And then we have leading structures and quality parameters. So the depth penetration should be, whenever you have no idea, 12 centimeters. If you have an idea, the organ should be in between 2/3 of the image and the focus at the same level. So you can see the aorta cranially and caudally quite nicely. And then have a look how the examination technique works.
Evaluation of the aorta cranially and direction and almost approaching the bifurcation is displayed right over here. Celiac trunk, superior mesenteric artery, left renal vein, pancreas, superior gastroduodenal artery, stomach, liver, intestinal structures, and the spine are also indicated.
So we have the anatomy in a longitudinal way. We have been focused in the first image of the aorta, and then around the structure, the topography, organ by organ identified. And then always
is examined also mandatory in a transversal plane, starting just below the sternum, perhaps by angulation a little bit cranially to see the upper parts. We follow the aorta with the arrow by adducting the depth penetration, continuously until the bifurcation.
Left arm is always on the machine, optimizing depth penetration, focus, gain, whatever, according to our quality criteria. Transducer, body contact is a secret of best examination. And do it longitudinal, transversal, and oblique. Supine, left lateral, standing position in all patients during the training phase. The anatomy for all organs, it's pretty much the same. So we have only to learn adequate visualization, the location, if it's dystopic, atopic, at the right place or wrong place, the size of the organ, the shape of the organ, the boundary of the organ, the demarcation of the organ, if it's sharp or fuzzy or whatever, the echo pattern, which can be classified as echo-rich, echo-poor, echo-free, or even more sophisticated. I will not go deep into that. And the entire architecture of this organ and the vascular architecture as well. That's true for spleen, liver, for kidneys, for all organs. Those are the structures, and if you awake yourself during night, you might tell that table, and if you learn it early, it will be very deep in your memory. So this is an organ, it has a longitudinal diameter, it has a certain location, it has shape, it has a boundary, it has a demarcation, it has the vascularity at the hilum. So all that criteria we have been mentioning are displayed. And then the topography of the spleen, for example, is the thoracic abdominal wall. It's the lung. No, it's the acoustic impedance change between the abdominal organ, and the lung. It's not the lung. The diaphragma, which is a muscle, and it's hypoechoic and not hyperechoic. It's the acoustic impedance. The aorta and its branches, the kidney, adrenal gland, the pancreas, tail of the pancreas, intestinal structures, stomach, small, large intestine, ligaments, and the heart is not far away. So everything, it's a list, and we can identify during our learning process, during anatomy, during ultrasound anatomy, the same. So it's a second list. We should be aware that we do not only examine an organ. By examining the organ, we are also examining the surrounding structures, and that's anatomy on the living. That's how to learn, and it could that's a panoramic image. So also ultrasound, not only computer tomography, can display 3D volumes or can display panoramic imaging as shown here.
So the spleen, take a breath.
Now we look for topography.
Include the splenocholic ligament,
Caudally,
parts of the left flexure of the colon, breathe normal. Take a breath. Stop. Splenic vein, and the causa pancreatis next to the splenic vein, breathe normal.
terminology, people tend to tell from one to two to the others in a certain language. Use the anatomical wording, which has been developed as basal nomina anatomica, and which has been adopted by the Paris classification, and it is superior, yeah, it's arteria, mesenterica, superior. Okay, we have to accept English is nowadays the most important language, so it's superior mesenteric artery. Those is the right nomenclatura we can use, but we do not use, we shouldn't use different terminology. If we do so, it's like Babylon. Not all of us will understand what we are going to tell. So, if possible, official Latin terms should be used, and in scientific language, some English expressions have been implemented and accepted. Nobology, right now that's an image of a fatty liver, okay? Have a look to the upper part, high frequency transducer, and now I reduce the frequency with that high frequency transducer to a better image. Now I use a deeper frequency transducer, and the image is getting much better. Then I decrease, even for that lower frequency transducer, the frequency, and then finally you can optimize the image reducing the gain and other parameters. There are, let's say, 5 to 10 important and 40 also important but less important parameters, and then you get a good image. It's all explained, also free to download on Nobology, on how to improve your image. Then often we tell the patient or ourselves it's a fatty liver. Even we have no idea what we induce in the healthy subject or in the patient if we are not descriptive. So let's talk about pretest probability. Don't give complex diagnosis. So if we have, for example, a patient with a fatty liver, it might be normal. But if he has diabetes mellitus, if there is in his family history something like a metabolic syndrome, if there is a risk of arteriosclerosis, if there are elevated laboratory data, if there are influencing factors, then the normal state of a fatty liver is still an image of a fatty liver, but a total different diagnosis. So let us be descriptive, brighter liver with acoustic shadowing, descriptive. Don't tell there is a fatty liver, because you have to know other important issues to understand and give that diagnosis. So here we have axial lateral resolution, bones and scales in a fish. So if you like to know if your transducer and ultrasound machine is good, get a fish and have a look if you can see bones and scales. Also Nobology in Doppler ultrasound, it's on one hand very difficult, on the other hand very easy. It's a table we have to follow on how to improve our image parameters, and if you know the big issues and could differentiate from the less important one, then it gets more easy to use color for our image of vessels. Very important pathologies. There are many conventional professors who do believe for students that nothing pathological to be determined, but it would be boring. And so why don't we be descriptive? And an organ could be at the right place or non-existent. There's a liver and retroperitoneum, but the kidney is missing. So that's a pathological stage you can describe. There's no kidney. The kidney can be as a horseshoe kidney in front of the aorta. That's a dystope kidney. You can describe it. The kidney is not at the right place. And then you can describe it's at the right place in the longitudinal diameter. It has a normal size that looks pretty normal. And then we can measure an organ. That's easy and objective. And it can be regular, too large, too small. That's an easy pathology everybody can indicate. It's descriptive. And here we have the Hirslanden duct. Whenever you see a measurement, something enlarged, go for detail. So we have a high frequency transducer. And then look for the reason. There's a 5 millimeter ductal adenocarcinoma, ductal. It starts in the pancreatic duct, here. And look for the reason. And you can identify there's a hypoechoic in comparison to the pancreas structure in the duct of the pancreas, occluding the Hirslanden duct. And then, finally, there's an incidental finding. There should be someone having a look. The smaller the lesion, better the prognosis, and you can cure such a patient by identifying the ductal adenocarcinoma at that location. For focal liver lesions, I have been describing the learning objectives, the anatomical criteria and the topographic criteria. So, it's the same for focal liver lesion. Adequate visualization, location, size, shape, boundary, demarcation, echo pattern, architecture, vascularity. It's the same as for the organ, for the focal pathological lesions. Same criteria. And focal liver lesion can be echo-free, can be hypoechoic in comparison to surrounding liver parenchyma, isoechoic, hyperechoic. And it can be strongly echoic. Echo-free, one might transfer into the diagnosis of a cyst. But we can describe it. Echo-free, focal liver lesion in the right liver lobe, echo-free, and let's say 7 millimeters in size. Cyst criteria can be described in more detail, but if we go for focal liver lesion, it can be hypoechoic. It can be isoechoic. You even might not see it. You need to have contrast or something additional to identify such a lesion. And it can be hyperechoic. All examples are hepatocellular adenoma. Very rare but important lesion, which is normally isoechoic because it's hepatocyte derived. Looks like normal hepatocyte. In a fatty liver, it looks hypoechoic because the liver is brighter. In glycogen storage disease, in certain diseases, it contains glycogen and other structures, so they are reflective, it's hyperechoic. So the same lesion can look under different occasions pretty different. And then we have echo-rich structures with or without shadowing. And this is a typical, how to say, calcification. So echo-free, a cystic lesion, fluid or a vessel, and very rich, echo-rich, and shadowing, some sort of calcification. But everything what we have been describing can be described in comparison to the surrounding organ by using the same terminology as we use for the organ. The anatomical, topographic, terminology, and reporting. Then the ethical issues for incidental findings, I already mentioned that we have been discussing if students on their own identify something pathological, how to handle it and why it should be done. in that way, and why there should be a responsible teacher as well, a clinician hopefully handling with such findings. Haven't had time to go deep into it, but there is a discussion and explanation, and there is an instruction on how to handle incidental findings. Teaching. First question was when to start. I mentioned as early as possible in your local situation, and then teaching simple is 50% theoretical knowledge, understand anatomical terms and to understand what we are doing, and 50% practical skills. So if I would teach a rule, it would be something like that. And then teaching material, we have that textbooks, we have that teaching videos, we have lectures, we have interactive learning. We have so many deductive elements which can be offered at certain institutions and in other perhaps not, but at least theoretical background, teaching videos, and now I do believe also in COVID times that simulators might stimulate us and give us opportunity in the morning, afternoon, during night. You can practice, and it should be available. There should be clear learning objectives for theoretical and practical issues, and examination technique videos. Currently I recorded 36 lectures, are 45 minutes for a certain content. I will go a little bit deeper into that shortly. And then we have the simulator and simulation. And where are we now? We are pretty advanced, and let's have a look how it is in reality.
Welcome from the Ultrasound course Bern. Prof, Salem, and Permanence, Hirslanden. We present the ultrasound course including 8 modules. Spleen, kidneys, pancreas, liver, biliary system, gastrointestinal tract, abdominal vessels, and pelvis. The categories we will explain in detail will be examination technique, the anatomy of the respective organ, topography, which means the surrounding organs and structures, and very important pathologies.
So we transferred the examination technique into a simulator, and then we have been, how to say, offering OSCE to test on one side and train on the other side. And the training I will show as well. Also there are, how to say, simulators with real ultrasound equipment on cadavers, on whatever, on phantoms. And there are virtual examination with mock probes, and they are not real ultrasound probes on virtual modeling. Likewise, I've shown in that model here, but there are also others. And how it could look like. So you can train on that simulator. You can see where your positioning of the transducer anterior axillary line 10s to 11s, intercostal space, the arm above your head, and supine position, for example, for the spleen. And you can see the ultrasound image. And then, if you measure from cranially, caudally correct and you look to your left side, your answer was correct, and it is green. So you can test yourself, your job or your task force to measure the spleen, and you can see it's correct, and you do not need a teacher or whatever. And then perhaps you didn't see the more caudal part, you put your caliper over there, still on the right position, but not the total length of the spleen. Your answer was not correct. Correct answer is between 9 and 11 centimeters for that respective spleen. We call it Kölnisch Wasser for 4711. It's a German joke, but I do not know how it is in English. Okay, so you get a task, measure the spleen. You put the transducer at the right location, if not, wrong. You measure, right measurement, correct, wrong measurement, it's indicated as wrong. So you interact with that machine, it is programmed in that way. And then it also includes hundreds of pathologies at a further step. So challenges in student ultrasound education. Who's teaching? It depends on regulatory bodies, professores, doctores, studentes, didactores, didactic people who do it in the best and right way with a theoretical background, with the training facilities, with practical issues, and so on. We include the simulators as a tool, which is a practical tool in our daily routine right now. And who is teaching the peer tutors? We have to organize something like that in a standardized way. It should be independent of people, it should be independent of the mood. If Germany has lost against Japan, my mood might not be such good, but I mention on how to improve it. And we need to have a teacher, teach the teacher approach in a standardized way. It should be pretty much the same in Cyprus and China and Switzerland. So specialties and disciplines, it's a big issue, I can't solve it, I don't go deep into that, who is doing the cardiological examination, OBGYN, whatever, unsolved issue. We can use telemedicine approaches. That means the role of telemedicine is important. I have currently a project in Colombia with teaching in rural areas where people cannot even be at a certain location. During COVID times, it's even more important. Artificial intelligence, I only mention, it's a huge, how to say, future perspective for us. Reporting should be standardized according the anatomical terminology. We have to have resources, equipment at the right place and organized in a certain transparent structure. We have that handheld ultrasound devices. Here you can see perhaps 5 to 7 millimeter pancreatic lesion using high-end ultrasound with contrast-enhanced imaging. But in handheld ultrasound, check it out, use it, try it, do your best. We can even see the same lesion. We cannot exclude it, we cannot do oncological issues, but we can try it. We can make the best out of those very, let's say, ultrasound machines which look like that. And they are downward to $1,000 US. They are Chinese manufacturers. And then we have to face quality issues if we, how to say, look for alternatives. We have to standardize. We have to have certifications as the rule for standardization and certification, and the role of societies we have to tackle. So, the EFSO website is a guide for better understanding. Many of those materials are on that website. I have discussed with you where are we now, what are our future perspectives, inspiring students just to do it, be part of it, bring it to a better and a higher level together with your regulatory bodies and friends in the administration of your university. And then finally, it should be structured, standardized, transparent, to all of us the same terminology for reporting. It should be learning objectives, defined, including anatomy, all that criteria we mentioned, topography for each organ, defined, and you can check it out. And then it will be vertically and horizontal integrated in your clinical education over time. So only in German so far, 36 clinical courses, 45 minutes, which mean 27 hours of lectures for basic principles, neurology, liver, biliary tract, all basics, pancreas, spleen, GI tract, kidney, the advanced courses for the same organs, then advanced applications for the appendix and structures like that, and finally going to new techniques like ultrasound, elastography. So we are working on an online atlas to collect images. You and your teachers can contribute to that. It's an open issue, and we are working hopefully together. And finally, invitation to all of you is have a look to the examination technique videos, use it. If there's something missing or wrong or could be better, send it better and improve image. For example, better visualization of the initial position of the transducer to me. Bring it into that video and we work together, win-win. You are all invited to use it and to improve it. And use the books, textbooks, which are free, available, improve them, give input and be part. Currently, we are writing on a paper, controversies and challenges in student ultrasound education. If you'd like to take over the chapter to prepare, contact me, you will be part of the party, and we can only do it together. And this is what I very much appreciated by the invitation here to Cyprus. Thank you so much for that invitation to come into a closer relation, to work together, having research projects together, to get an idea on how we stimulate ourselves for better student ultrasound education in the future. Yeah, so what we have been telling in German, in English, in Spanish, in Chinese, so the entire project has some sort of future ideas. There's a European Congress also with students in Riga, beautiful city, not too far away from Russian border, but still in a safe place, beautiful. And there is in Oman, the Rhythm Congress, very nice people. So be aware, there are places to meet in Cyprus, in Riga, in Muscat, in Oman. We are all a big family. So thank you for your attention. Looking forward for the discussion.